So today we're going to do femoral nerve block in a patient who is undergoing ACL ligament repair. Of course, there are many different options when it comes to interventional analgesia. They can consist anything from the femoral nerve block, femoral triangle block, or a diatic canal block. And the differences among those approaches really depend on how intense analgesia one wants to accomplish and whether the patient is expected to ambulate. If the patients are not expected to ambulate the first 24 hours after surgery, then most definitely the femoral nerve block at the femoral crease is the most effective and powerful interventional analgesic. Okay, so let's get started. What we have here is the patient in a supine position. The groin is prepped, and here we can see the external anatomy landmark, which is crucial. And in this particular example, it is the femoral crease. Now notice how the femoral crease is actually different from the inguinal ligament, which is oftentimes described in regional anesthesia textbooks. The anterior superior iliac spine is up here, and the pubic tubercle is over here, and therefore you can see how the inguinal ligament is much higher than the femoral crease where the block is actually being performed. So we do not perform a femoral nerve block at the inguinal ligament level because in those instances the femoral nerve is much more difficult to access and you may also enter the pelvic cavity. Instead, we perform a femoral nerve block always at the femoral crease. And here we can see the sleeved ultrasound transducer as well as exposed skin area, and our superficial anatomical landmark is always the femoral crease. Even in the most obese patients, the femoral crease can always be seen, and if it's not seen because of the large belly, all you need to do is retract the belly on the side with a tape or with a helper, and the femoral crease immediately becomes apparent. Here in this particular image, we see the femoral artery and the femoral vein immediately medial to it. As we apply the pressure on the transducer, we can see how the femoral vein collapses and opens up. Lateral to the femoral artery is the femoral nerve, which is enveloped in two layers of fascia iliaca. Above that, we can see also the fascia lata, and underneath the fascia iliaca, of course, is iliacus muscle. Posterior to the artery, we also see the post-enhancement artifact, which is not a nerve but an artifact actually, and more lateral and superficial. We also see the sartorius muscle that is positioned just above the iliacus muscle, slightly lateral to the femoral nerve. Now, to perform a femoral nerve block, what we would like to do is place the needle in between the two fascia layers, and the correct injection of the local anesthetic will displace the femoral nerve. Here's a couple of stock maneuvers that we use to enhance the visibility or accentuate the femoral nerve. So the first thing that one could do is, you could see this is a wrong angulation of the probe or wrong tilt, but if you apply a little bit more distal tilt, as you could see, then the femoral nerve really stands out. The second maneuver you could do is apply pressure. Application of the pressure causes compression of the connected tissues, and because the femoral nerve is less compressible than its surroundings, such as the muscle and the fat, it always tends to flat out and becomes a bit more prominent from the neighboring anatomy. Okay, so in this particular example, we're going to do an in-plane needle insertion, and the goal of the needle insertion is that we're going to place a needle in between the two layers of the fascia. In this particular patient, we did not use any local anesthetic for the skin because routinely we administer pre-medication, which here consisted of 5 milligrams of ketamine S, which is a levoisomer of ketamine with less psychotropic activity, and 2 milligrams of midazolam. So here we're going to stay away from the nerve to avoid the chance of the needle piercing through the fascia iliaca, lodging into the femoral nerve. So we're going to go lateral to the nerve, we enter the fascia. Good. So we now think that our needle is positioned between the two layers of the fascia iliaca. We're going to stay there. The next step that you want to do is slack of the pressure that we applied. So slacking of the pressure will allow you to allow local anesthetic to displace the femoral nerve between the two fascia. Okay, it's time now to employ the RAP maneuver. RAP maneuver stands for response is absent. We typically use nerve stimulation as one of the three monitoring methods. The nerve stimulator is set at 0.5 milliamps, and if the needle by any chance lodges onto the femoral nerve or enters the nerve, it is very common that the motor stimulation or distal motor stimulation occurs, letting us know that we are in a dangerously close position to the nerve. So the second letter of the RAP stands for aspiration, A for aspiration, and here it is negative, and we always look at the tip of the needle. Therefore, we specifically hold the needle in such a way that the tip of the needle and the tubing is always at the hub visible to the operator, so he can immediately determine if the aspiration results in a blood. And finally, the P stands for the pressure, meaning the opening pressure must be always low. If the opening pressure is high, something is abnormal. Either the needle is lodged into the fascia or into the fascicle. So here we're now going to aspirate, negative, and here's the initial injection. Here we can see the opening pressure is rather low. An example of a high opening pressure would be something like this, where you see the colors on the piston of this particular device, meaning that you require a lot more pressure than normal to initiate the injection. So again, opening pressure is fairly low. So let's see what we're doing here. So as we look at the ultrasound here, we can see that the local anesthetic injected spreads above the femoral nerve and pushes the femoral nerve away from the needle by the local anesthetic. Every time when you accomplish displacement of the nerve or nerve structures that you're trying to block, that really is 100% sign that you are in the correct tissue layer or tissue fascia. We can still advance the needle slightly closer, that's good, towards the posterior fascia, but not towards the femoral nerve. And again, RAP maneuver is response is absent, aspiration is negative, opening pressure is low, and now once we see the displacement of the nerve that completely occurs between the two layers of the fascia or the fascia iliaca, we know that we are in a perfect position. So here we've used only 8 milliliters of local anesthetic, but clearly we don't have to use more, because here you can see the nerve completely surrounded by the local anesthetic in between the two fascial, stay there in between the two fascia layers. So you can see the fascia iliaca there, you can see the anterior layer of the fascia iliaca over the femoral nerve, and you can see the posterior layer of the fascia iliaca with the local anesthetic that completely encircles the femoral nerve.